So let me tell you a little bit about Decatur, and then we'll talk about some of the things that we've accomplished there. In 2012, Decatur Morgan Hospital became part of the Huntsville Hospital Health System, which is made up of about 7 different hospitals across North Alabama currently. We are 4 campuses within Decatur Morgan. We have the Decatur campus, which is the larger of the 2 acute care hospitals. Then we have the Parkway Campus Hospital, which is about 6 miles down the road. And we also have a psychiatric facility. It's a 64-bed and serves all 4 pods there with children, adolescents, adults, and geriatrics. And then we have an outpatient rehab center that is thriving. We have about 1,300 employees. We have about 238 physicians. And all total across the 3 acute care facilities, we're 300 beds. Our average daily census between those is about 170. And so our EDs are very busy and see about a little over 65,000 patients annually. So that's enough boring stuff about Decatur. So let me tell you about the really fun stuff. In mid-2014 or so, and I know that sounds like a long time ago, but time has flown by in the last 5 years, we began to look at what we were doing at Decatur. If you've been in healthcare for a long time, you remember that in 2014 we're in the midst of the core measure era. Anybody remember core measures and how much fun they were? And we started out with about 20 or so core measures in the early 2000s, and by the time we were complete in that era and starting something new, we were at 165 core measures. And so if you know about core measures, it's all tied to reimbursement, so everything had to be done and done correctly. And so as hospitals began to embrace core measures and the national patient safety goals and everything else that was being pushed down to us from our regulatory and reimbursement folks, we pushed everything to the bedside. Everything went to the bedside RN. And so that's what facilities did. That's what we did at Decatur. That's what every hospital in the nation did. Everything got pushed to the bedside. And so what we did at Decatur was to support nursing during all that was absolutely nothing. We gave them all these things to do and said, you continue to do what you've been doing and you do this as well. And so you may remember that we were in this checklist environment. You had these long checklists as an RN at the bedside, and you had to check off everything at the end of the day and make sure that that charge nurse or your director knew, I've got my checklist done. And so if you're a nurse in the room, you didn't go to nursing school to be the checklist person. You went to nursing school to be a compassionate caregiver and take care of folks, take care of patients and families. And so that led to a very dissatisfied workforce in nursing because RNs were checklist people. They lost having a relationship with patients. They lost having a relationship with families. They were dissatisfied in their job, and they left. And they turned over, and they floated from organization to organization. And so we had to figure out, what are we going to do to stop the bleed? Guys, I'm ashamed to say that on a couple of my med-surg units that I was managing at the time, our turnover rate was in excess of 39%. One of them was a little over 40% a year. That's almost half of the RNs turning over on a med-surg unit. And when you're talking about operationally managing that, it's a pretty scary place to be when you've got new staff just continually coming in. And then you've got the staff that have been loyal to you or trying to train all these new staff members, and they just keep going out the door. So it's a perpetual bleed. So I remember one day going to my boss, who we've worked together for years, CNO, and I said, my grandmother had this little framed saying in her house. Albert Einstein said the definition of insanity is doing the same thing over and over and over again and expecting a different result. And that's what we were doing. We were just handing all this stuff, and we just kept doing the same thing, and nothing was changing. And so we began to look at what we could do to improve the patient experience and really enhance our retention. So using the nurse call system, we measured movement of an RN. I just wanted to see what that looked like. What does it look like for an RN on one of the med-surg units to their morning? And so this spaghetti diagram you're going to see here is 2 hours from 7 a.m. to 9 a.m. in the morning on a med-surg unit. And so this RN had 40 position changes in that 2 hours. And he spent about 33.3 minutes in the patient's room with an average time of over 2 minutes in every encounter. And that's like really not a good thing. So from 7 a.m. to 9 a.m. in the morning, if you don't know, on a nursing unit, you're doing patient assessments, you're delivering medications, and those are your main things that you're doing and at that 7 to 9. So why in the world would you need to go to the soil utility room or the clean utility room? Or why would you need to go any of those places? Why would you need to make 15 trips to the central nurses station? And so in my Pollyanna world that I was trying to live in at the time, it was like, okay, in the real world, in a theoretical world, he should be going from his 6 rooms, from room to room to room to room in those 2 hours. You'd never have to go anywhere outside the patient room to do anything. And so we began to look at what we were doing, and we sat down with these folks and started to really dig in to see what it meant to be a nurse at Decatur Morgan Hospital. And I have to share my epiphany moment. We talked about Code Browns last night with my friend back here at dinner, and that was great dinner conversation, by the way. So my epiphany moment was one day I came off the elevator on the 4th floor at my hospital, and our registered nurses wear royal blue scrubs. And I saw one of my favorite nurses on that unit walking toward me, coming the opposite direction, and had her royal blue scrubs on, and she had a plastic bag in each hand. Our bags are clear at Decatur, so I could see exactly what she had been doing. And she did exactly what she should have done. She took care of the patient. But I did know from my times at the bedside, judging on the complexity of all that linen and the things that she had in those 2 bags, that she had just spent about 20 to 25 minutes working to get that patient cleaned and powdered and puffed and comfortable. And so here was my thought. Here was my epiphany moment. I'm glad she did that. She did exactly what she should have been doing. But what if someone else could have done that, and she could have spent that 20 or 25 minutes at another patient's bedside teaching them about that new medication that they just got prescribed, or teaching them about that disease process that they just got diagnosed with? How much better would that be if we could support the RN with someone else who can do that job that really doesn't require a license? And so that started our journey. That thought process started where we went from there. So we sat down with a group of registered nurses at our hospital. And honestly, guys, I sat down with folks that had been loyal to us and who I thought would, give us the most honest feedback and input. And then we had a couple in the room who were the naysayers as well, just to get a good mix of those folks that we wanted to redesign nursing. Because one way or the other, the mission was we were going to redesign how we do nursing at Decatur. And we looked at our HCAP scores as a benchmark, because we were horrible in the areas that we needed to be really good in, and education was one. Patient education was the one thing that I discovered, or we discovered as a team, that was being left out or put on the back burner because there literally was no time to do that, because that RN was in the room doing tasks that did not require a license. And why was she doing that? Because we had no one else to support her in that role. And so this is what it looked like when we began to design. We had bedside nurses that started designing. The one thing that my boss and we decided up front, this cannot come from us. We cannot push anything else down. We've been pushing down for 7 or 8 years now. They're not going to listen to us. They must be the ones who redesign it. And so we put those RNs in a room. We gave them some talking points and a little guidance, and they began to design what that would look like. So the first thing we did was have them design their job description, to write it. And I have to share this 30-second moment. We got in that room, much like this one, around tables, and we talked about that. I said, okay, guys, in 2 weeks, we're going to come back to this same table, and we're going to sit down, and we're going to hammer out a job description, or at least get it started for the registered nurse at our hospital. And I just have to confess, I got a little misty when I came back in 2 weeks, because these people took this very seriously. They came back with armloads of research they had done over that 2-week period. And over the next 6 or 8 weeks, we hammered out what I believe to be one of the best RN job descriptions around, because it does not have a single task in it. Not a single task is in the job description. It's about relationship. It's about relationship with patients and families, and the physicians and the people that you're working with every day. And that's a pretty neat thing. And it was hard to accomplish that, actually, but we did it, or they did it. We just helped guide them through it. So the other pieces of the nursing model that we had to put in place, that we felt was really important, is that the nurse director had to be relieved to spend at least 50% of his or her time on the nursing unit. Why is that important? It's about relationships. We talked about this at dinner last night too. Our nursing leadership in any hospital across the nation, they're managing 4 to 5 generations. And everyone is very different, and how you manage them and how you communicate with them, how you relate to them is very different. And it takes somebody with a lot of skill, but they also have to have the time to do it. So we worked on that. I won't go into the details, but I'd be happy to discuss some of those later with you if you'd like to hear that. And then we had to look at the charge nurse role on the units. Charge nurses in a lot of places, they come in, they take a patient assignment, and they just get deemed the charge nurse. Can't work that way, especially on big med-surg units, which is our initial focus. Charge nurses have to be trained, and they have to have autonomy and empowerment to run the operations of the daily on that unit. And that's where we needed to get them, and we did. Then we wanted our registered nurses to spend at least 70% of their day, their 12-hour shift, in direct patient care. And that was a huge and lofty goal. And we've had some great success, and we've had some bumps in the road that I'll tell you about in just a minute with that. But we wanted 70% of the time that RN to be in the patient room, which meant that's about 8.5 hours of their 12-hour day, if you can imagine that. So the mantra of in that last bubble up there, the mantra of the model is that everybody works at the top of their license. And so that means that registered nurses are doing things that registered nurses are trained and licensed to do. And we support the registered nurse with non-licensed individuals doing everything that they can do that doesn't require a license. As for our case, the Alabama Board of Nursing allows that non-licensed individual to do. And so well-trained nursing assistant, working with an RN as a team together to accomplish great outcomes in patient care. So that's where we started. We started in June the 8th of 2015 was our go live day. So we're coming up on our 4-year anniversary. And so I'll talk some more about how we got there. So the key roles, I've talked a little bit about this, the key roles of the model. Being the charge nurse, the charge nurses do manage the daily operations of the unit, and that's 24/7. They supply director support and staff support, but the charge nurse role is integral, and I'll talk a little more about when I get into talking about how we're using technology. Charge nurse is integral in using that technology, especially the nurse call, and I'll talk a little bit about that in a second. I just talked about the RN and nursing assistant care team. It is about the RN having a nurse-patient relationship and supporting him or her with a nursing assistant that's trained to do the tasks that need to be done. We also added an LPN medication nurse to that model. And so here's what that meant and how that's worked for us. We talked to some folks from Novant Health, it's up in the Carolinas, that were doing a very similar model, and we learned a lot from them. We didn't create this, and on our own, we did have a lot of input from other areas, but Novant had done this particular thing in their model, and it really intrigued us. So I heard a talk from one of their representatives at a conference that year, and they put out the statistic that their RNs were spending an average of 26 minutes per patient per day at the PICSs, or at the automated medication dispensing system that might be in their hospital. And I'm like, there is no way that's happening in my hospital. They're spending 26 minutes per patient per day standing in front of that PICSs machine. After all, I had added another station, on all big med-surg units, so that line was decreased and so on and so forth. That happens in hospitals, and so I was determined to prove them wrong, that didn't occur in my hospital. I went back and we measured the RN's time at the PICSs, and it wasn't 26 minutes, it was 28. An average of 28 minutes per patient per day at the PICSs machine. Well, that had to stop. There's no way we could get our RN back to the bedside 70% of the time if they're actually spending 70% of the time in front of the machine pulling medications. So we added the LPN medication nurse, and here's what they're doing. They're pulling the routine meds for the patient from the PICSs. And they bag them and tag them, and they're in a locked cabinet, and the RN goes by, pulls that bag, and off to the room he or she goes with their medicines. Well, that's a 30-second venture per patient versus a 28-minute venture. And so, but not only do they pull in the routine meds for the registered nurse, they're also following up on the medication reconciliation piece of what we do for patients. And they also stock and, send the discharge medications back. They are the liaison between the RN and the pharmacy. I don't know if y'all been around hospitals a lot, but that phone between the pharmacy and the RN can monopolize the day. If you're always waiting on something, or waiting on a phone call, or calling to see if something's ready, we virtually have cut all that out because we've got that LPN that's in the medicine room, that's in that liaison. So an RN knows if that medicine has not been handed to me, that new medicine that I'm supposed to give, if it hasn't been handed to me, then it's not ready. I don't have to worry about that because somebody else is worrying about that for me, and I can go about doing the other things that I'm assigned to do. I can tell you today, if I was going to adjust anything and I went into our team and I said, hey guys, we're having some cuts, we're going to have to get rid of the LPN medication nurses, I would have a mass exodus. It's the most celebrated part of what we do in the model. All right, then there's the unit director. Had to really cut them loose from a lot of clerical things that they do because it monopolizes the time in the office, and get them out on the nursing units. All of our nursing directors, I'm proud to say, at this point in the game, have moved from that more of that autocratic kind of leadership to being a transformational leader, and they are truly leader coaches at this point, and I credit that a lot to our success with reducing our turnover. So there are only 4 non-negotiables in the model, and here they are. Documentation inside the room. We went live with our EMR, it's Meditech. We went live with that in 2012. We put a computer in every room. We thought this would just be great because we also went live with bedside medication verification at the same time. I wanted a computer in every room because I wanted the staff to be able to document in the room instead of having to roll around something that the battery's going to die on and that kind of thing. So we worked, through all that, through the that planning process for initiating the EMR. But guess what? If you go back and look at that position changes on that RN that I showed you at the beginning of the talk, they weren't documenting in the room. They did use, they had to use the scanner to give meds, but they were not documenting their assessments and things in the room. And so all those trips back to the central nurses station to document. And so when I started asking questions about, well, why aren't you documenting in the room? And then I get answers like, well, the patients talk to me if I'm documenting in the room. I'm like, well, great, talk back to them. So we did a lot of training with our staff. We'd already done a lot, but we've gone back many times and retrained our staff, and it's heartwarming to go walk the unit now and see an RN sitting in the chair at the bedside with the computer pulled over, talking to the patient, explaining things to them as they're documenting. It's just a good thing. That's how we've used technology to support some of what we do. Bedside shift report is a non-negotiable at our place, using the care board and keeping that updated. And a non-negotiable for us as well is using the iBed status. We have Stryker S3 beds at our facility, and I'll talk about iBed in just a few minutes, but it's a non-negotiable. Every patient must have an iBed status set, and it must be integrated with the nurse call so that they can get notifications if they have issues. It's a safety thing, and so I'll talk about that in just a second. So with anything you do, there's lots of challenges, and what I found out is that he who hath the football will be tackled. And so often I was running with the football and would get tackled because things did not just work out rosy like we had it planned in the beginning. There were lots and lots of hiccups and lots of mountains to climb, lots of lean projects to work through because you'd find out what you'd planned didn't work at all and you had to go back and do it again, right? So what we found is that folks are really nostalgic about the way things are. Change is not something that nursing overall embraces. They would rather just keep doing what they're doing rather than to change something because after all, we don't know if it'll work or not, so why go through the trouble to do that? So that was a lot of work to do to get people to embrace some change. I also learned that nursing patient ratio is imprinted in every single person's mind. Today, when we interview new graduates out of a college, the first question they ask is, what's the nurse-patient ratio? And when you tell them at Decatur, the nurse-patient ratio on day shift on med-surg is 1 to 6, and it's 1 to 8 on night shift, that will shut them down often because it's not that way at other places. But if you can get them past the ratio and can talk about the support they have underneath them, you can usually get them won over and talk to you. But ratio is a big deal. It's imprinted in everybody's mind, especially in nursing. We were introducing new technology when we started this. We were about to install critical alert systems in our big units around that same time. We were looking at how we lead. And, you know, I didn't lose any directors in this. All of them embraced the change and how we were going to do things. But we did lose some leadership. We lost some charge nurses that just could not embrace change and could not change the way they led. And that was okay. We helped them find another place to go, and we had a couple that exited the organization. And that's not a bad thing because now our leadership is strong, and we have a really good team. And so that was something that had to happen as well. And we really had to embrace that transformational leadership style and that coaching conversations. And I always talk about coaching and conversations over and over again. If you don't do that and you don't have that inbred in your culture, you're going to lose out at some point. So those are the things we had to challenge us. So in order to make anything successful, we had to look at the technology that we're using. And I think that's a lot of what we're here to talk about today and how we utilize technology to support the system, not us to support the technology. It's really important to not flip those. It's not to make the technology work. It's to make the technology work for you. And that's, we've had a lot of good success with that. We do have critical alert system, nurse call, our electronic medical record ourselves, Meditech. We also have a computer in every room, and we do bedside medication verification, and we use the patient bed to help us keep patients safe. And I know that not every hospital has that luxury and that integration, but we do, and we're very happy to have that. And so in optimizing that with critical alert and the S3 bed, I talked about iBed status just a few minutes ago. And that integration allows, of course, for nurse call and bed exit. Those are the two main things that a lot of people talk about. But we also have other things that are integrated. The bed position, the side rail position, the breaks, everything feeds information to the nurse call system. So that's why we require the iBed status to be set on every patient. If I've got a patient in the bed, I need them to be at 30 degrees Fowlers. I need the brakes on. I need the bed in the lowest position. I need the bed exit set on module or 2. I've got all that set. I want 3 side rails up. All that set, and I push a button, and I'm there. If anybody disturbs that, I'm going to get an alert through the nurse call system to let me know that something's happened to my bed. The patient's moved. Somebody's come in and let a side rail down, and families are really good at doing things like that. And I'll show you in a few minutes how that's really helped us cut down on some falls and things that occur. And so when I go down the hallway and I don't see that green light illuminated on the bed, I'm asking questions right then. Why is the iBed status not on? And if it's orange, I'm wondering why people are not in the room and taking care of whatever that happen. And so we've trained over and over again our ancillary staff, like physical therapy that comes to the room, or the lab techs. They know how to operate the bed as well, so they can, turn it off when they're doing their work and then reset it when they leave. So it's a safety thing, and we need to use every piece of equipment and technology that we have to support our patients being safe and well cared for in our hospital. So the next thing that I use Critical Alert for is reporting. One of the most robust reporting systems I've ever seen in a nurse call, and we'd used another, pretty sophisticated nurse call in the past, but the reporting with Critical Alert really attracted me to that. We've actually worked with CAS and Decatur's worked to design a couple of reports, and that they've readily helped us with to support what we're doing, and that's another great thing about working with the company. But the presence report we use every single day, every shift at our hospital. I told you we measure the RN's time at the bedside. So the presence report helps you measure the RN's time at the bedside. Actually measure every staff member, nursing assistants as well. And it is posted every day on the nursing units. And so they know what their time was the day before. And so that's driven over the years a lot of competition. And I know that you may think, well, there's people that will just go stand in the room, or they'll leave their locator in a room or something. We've faced all those things, and we've overcome a lot of them. There's a healthy competition between the units about their time at the bedside averages. So all that's a really good thing, but we do use the system to do that. The performance reports really help you understand when staff is moving in and out of the rooms, knowing how long that they were there. I really look at nursing assistants and performance reports, because I know that a bath takes about 20 minutes to do. So if I've got a nursing assistant that's been in a room and the longest they've been in a room is 2 minutes the whole day, something didn't happen right. And so we look at those performance reports. I don't use them every day, but we look at them 3 or 4 times a week just to spot check folks, to make sure that we've got people in rooms when they should be. We look at those performance reports also to help us with looking at our hourly rounding, to make sure there's a staff member in the room every hour. And there is an hourly rounding report that we use as well, but it's more of a global report, and it helps us see things, but that performance report really helps you drill down to exactly what's happened in the room. I use other reports from Critical Alert, the call volume by unit and time of day. Those are things that really help you understand where you need to concentrate folks, and can anybody guess on what time of the day that calls are usually higher? And it's always when people are at lunch. Why is that? If you look at it any day, between the 11 and 1 o'clock hour during the daytime is when your call volume goes up. And so it's because people are off the unit, or they're in the conference room having lunch, or wherever they do that, so there's less people on the unit, so the call volume goes up. We've worked diligently to try to reduce that. We have had some success in reducing call volumes during those peak times, just by having everybody round on their patients, before they go to lunch. And, of course, sometimes that can take up your whole lunch, 30 minutes trying to do that. But all that said, those reports really help you drill down in the places where you need to work. And if you didn't have that, it's just a guessing game. And so we really have maximized, I think, utilizing the reports that Critical Alert gives us. The other things that when you're talking about a nurse call system that I had to sell to the folks when we were ready to buy, because everything you add on, is a little more money, right? And so you really, in our environment, our reimbursement environment in Alabama, you really have to account for every dollar you're going to spend. And when I ask for real-time locate, it's like, well, what does that mean? Well, that means that I can find everybody I need to find on my unit and know where they are and measure their performance. Okay, well, that's kind of a no-brainer. And then you get into, what is that really going to accomplish for you? And you start to move through that and realize, my goodness, it's just, why would you not have that? Why would you not want that real-time locate function? And then the ADT, that was kind of pricey too, kind of talk about that. And I'm like, why would you need that? Can't somebody just admit and discharge those patients? Well, if you know hospitals well and med-surg units, you're turning over, I got a couple of 42-bed units, and they'll turn over 20 patients a day, discharge and admit them right back. So imagine that, trying to do all that manually and keep up with it. So the ADT function, you just can't do without it. It helps help the staff. I mean, it's a great function. After you sign on, we try to do that with everything we do now, because who wants to remember 15 passwords and have to change them every 6 months? The workflows. The workflows is probably the integral part of what is attractive about Critical Alert, is being able to set those workflows and the escalations in them. And it's very customizable, which is what really attracted me to that. And we use that often, where you can set a workflow. For instance, a pain call. And a patient, calls out they're in pain, and you've got a workflow that instantly starts with CAS, and then you begin to watch that escalation through as people respond or don't. And so that has been integral to us being successful with increasing our HCAP scores and supporting the staff. If I'm a registered nurse and I'm tied up in another room and my patient needs pain medicine, I got a buddy assigned to me who's got the next assignment down the hall. And if I don't make it in a certain amount of time to that room, then that buddy gets the page. And then it escalates to the charge nurse after that. And that's how we set things up. And so when you start building workflows with CAS, again, it's very customizable, and you can go back and tweak those and make it work for your staff. And nothing's like set in stone that you can't go back and tweak things. And I use the pain example. When we initially set our workflows up with pain, I personally was really aggressive with that. I was like, 2 minutes. Got to be 2 minutes, and we're going to escalate that call. Well, sometimes you can't walk from one end of the unit to the next in 2 minutes. And so, the call would escalate just really fast. And so you had everybody getting these pages that, we've got this pain medication. In 6 minutes, 3 people's gotten a page. And I found out really quickly what that does to your staff is put them in alarm fatigue, and they start getting desensitized to that notification. And people are still getting their pain medicine within 10 minutes or so, which is pretty reasonable on a med-surg unit. And so you begin to tweak those escalations and those workflows, and it's really easy to do. And that's the good thing about the whole system. It's really easy to operate, and you make it work for you and for your staff and for your patients. I talked about the buddy system. We use the buddy system. A lot of people don't do that, that have it, but we use it every day religiously. Everybody has a buddy assigned. The charge nurse is responsible for going into the system and making those assignments before the shift starts. And everything's assigned, everybody has it, and so the ADT follows all that. So when they get assigned a new patient in a new room, all that just it flows, and it just makes it happen, and it's fluid and seamless. So to show you a little bit of our results from what we've done over the past few years, our baseline, RN time at the bedside was 28% that we measured. We set that goal of 70. We're running, on average, 66, 68%. I do have one med-surg unit, was our early adopter, and has really embraced the model more than any of the others in the hospital, and they run an average of 73% on that unit, and the others are running in the mid to low 60s. Nothing to say one against the other, but they've figured out how to make it work, and their leader is exceptional, and I think that's a lot of it as well. So there we are. We've made some progress in the last 4 years with that. So the couple of HCAPS domains that I looked at initially, because we were so really low in those, was communication about medications. We were not teaching our patients. We were not giving them any information. They did good to get a printout at the end of their stay. And so we've moved that from the 19th percentile back in those days, and I'll tell you, in a couple of those units I'm talking about, they were in the first percentile. They were bottom of the barrel. That 19th was the average of the hospital. And today, last year measurement, we're in the 95th percentile. Discharge information, we weren't doing real well with that either. We still struggle from time to time with patients really understanding all that information we give them at discharge. We do the follow-up phone calls. We do a lot, to support that after the discharge, but we're running in the 75th percentile this last year with that. Bedside shift report back then was not measured, neither was communication, the communication boards, but we're in the 95th and 91st percentiles with those, and you remember those were on my non-negotiable list for making things happen and changing our patient perception. And overall, I feel like we've done a really good job with that. Then this is the one I'm probably more proud of. I've been at Decatur for 26 years, and this is the first time ever that we've been in the single digits with RN turnover. And currently, we're in our third quarter of our fiscal year, and we're at 7%. And that's just never happened before. And when you talk to our staff, they will tell you that it's because of their leader and because of the support that they have and the model. And we've been able to not just put it in med-surg, we have it's bled over to ICUs and the step-down units. And this last year, we've worked diligently with our West Campus, which is our psychiatric facility, to support them in a different way as well. And so it's really working out well for us in that respect. I'll tell you a little story. Last week, one of my directors called, and we're opening a new unit in the next couple of weeks. And so she's interviewing for staff for that unit, bringing on about 20 new staff members to staff that small unit. It's a dialysis unit. And one of the nurses that she interviewed said when she saw an opening come open, she came here because, this is a quote, "In the nursing world, we've heard about your model, and I wanted to come see if it really is what you say it is." And so that was pretty encouraging that that folks are being attracted by the support that we've been able to offer, not just from personnel, but from the technology and the support that we've given. So this is another thing that I'm really proud of. I mean, we've worked hard to use, again, the technology, the iBed status and critical alert. When I'm on units and rounding and I hear a bed alarm go off, suddenly, just like it's, people are just going to that room, and it's because they've all been alerted that something's not right in that room. And so this last quarter, we were down to 1.6 falls per 1,000 patient days. The national benchmark is 3.4, and so we're driving that down, and we're striving for 0, just like everybody is, but it's a pretty significant decrease in our patient falls. And I just share the good stuff. We've got some stuff that we're still working on, but we've made a lot of good accomplishments with a lot of the things that we've done. So a year later, after we started, this would have been in 2016, this was another nurses movement in that 2-hour period. And so we're down to 26 position changes. She was spending 72.98 minutes in the patient's room, which is just a little over 70% for that 2 hours, and about 4.56 minutes on average with each patient. So when I begin to look at her movement, you'll see there was a lot of movement to the med room, and I expected some of that because during from 7 to 9 you're given some medications, and so but I had to know why she went between 4:59 up there. She went from that room to the med room 3 times, and I just didn't understand why she would have to go 3 times. So I went and asked her, "So why did you move?" She said, "Well, it's funny you ask. I got in the room and I needed to crush a med, and I didn't have a pill crusher." Oh, okay. And then the other time that she had to go back to the med room, she needed some applesauce because this patient needed to put their meds in applesauce and eat. That's how the patient took her meds. And so I'm like, okay, well, all of that should have been ready for you when you picked your meds up. And so those little things is what we began to tweak and make better for the staff. And so now it's not just the medicine in the bag, the syringe, the alcohol prep, the pill crusher or cutter or whatever it is supplies that are needed, the applesauce, the pudding, whatever it may be, all that is ready for the RN when they pick up their stuff. So it's not a back and forth. So we cut out 3 position moves for her on one patient just by adding those little things to what she was doing. And that's why I still share this slide. So we made improvement, but since then we've made even more improvement with those things. All right, I've talked a lot, so forgive me for that. But are there any questions about anything we've talked about? Yes, sir.
So your turnover was fantastic reduction. What would you say the top 2 things that impacted that reduction in turnover?
The top two things: leadership, number one. Our unit leaders have really made those changes and moved to that transformational leadership style. And two, it's the support and the community in our hospital, the culture. Those are the things.
Brian, how many LPNs or CNAs did you have to hire when you changed over?
We started on two of the big med-surg units. So initially, we hired 14 new employees, either nursing assistants or the LPNs. And I want to tell you where those came from, because that's a good question, because a lot of people ask me, this is cost prohibitive, how could you afford this, and so on and so forth. I told you our turnover was astronomical, and we had positions sitting on our posting that had been RN positions that had been on our posting for months, some of them even longer than years. We could not attract RNs, so we took those vacant positions and had to sit down in the boardroom with our president and say, look, this is the dollar amount assigned to these RNs. There were 9 of them. I said, I need to turn these into nursing assistants and LPN. So we took the dollar amount assigned to those, and in our world, I don't know why it is, especially folks that are in leadership that are not clinical, that it's an FTE is an FTE. Well, the $70,000 FTE is much different than the $25,000 FTE in my assessment because of the dollar amount. We had great success with that. I don't mean to say we didn't, because they got on board really quick with us. So we turned those 9 vacant RN positions into 14 positions for nursing assistants, LPNs, to fill the vacancies we needed to make the model work. So it worked out great for us. And since then, we've moved things around. We've done a lot of other things to support our staff. I didn't say this initially. We did add a discharge nurse to our big med-surg units to work with the complex discharges. That's helped a lot to improve our transitions scores and things like that. And we also have added a couple of folks in our education department to really help target new employees. And so every employee, I only have a couple of these folks. Don't think it's a big team, but they're very efficient what they do. But every new employee that comes into our service line is assigned to one of them for a year, and so that's their person they can go talk to. If they don't want to talk to the director, or, if they're having issues, it's kind of their liaison to talk to, and they've done a great job in supporting our new staff. So that's helped with our retention as well.
Thank you.
Thank you.
Brian, one other question. When you were implementing this structure,
Mm-hmm.
As you came up with the plan that you were going to do, was there pushback by these people, the non-clinical people at the top, in terms of what this would entail and how much time would be involved?
There was no pushback from upper management administration, if that's what you're referring to. I didn't get any pushback. I think we did a really good job communicating the need and how we would get there, or at least the initial plan. And so we had a lot of support, actually, from administration, and we needed that to make it work, because this was a big project. The only thing that I had from the president of our company was failure's not an option message. And so, yes, sir, we're going to make this happen. And, the thing that we kept hearing is, all you're doing is just adding a nursing assistant. Well, no, that's not all we're doing. If you had just tried to team an RN and a nursing assistant on the floor and said, go forth and prosper, it would have fell flat in about 2 weeks. I mean, it would not have worked. It was about changing and evolving in a culture that first of all fostered that relationship, with the leadership and the staff, and then that bled, over into the relationship with the patient and families. But no pushback there. Where I got pushback, interestingly, was from long-term RNs and nursing assistants that had been working in an environment that they didn't like, but they struggled with change. I had registered nurses that had been for so long responsible for giving the bath and taking patients to the bathroom and changing their bed, and all those things were so ingrained in their day. When we pulled all that away from them and they didn't have to stand at the Pyxis to get medications. All of a sudden, it's like, what do I do with my time? And I actually one day, I have pockets of things that are ever in my mind that happen, but I had an RN standing in the middle of the hall, and she like made 2 turns, like turned around a couple of times, and I said, "What's going on?" She said, "I really don't know what to do. I don't know what to do with my time." And I really felt sorry for her. She'd worked for me for 14, 15 years, phenomenal nurse, and we had that conversation in the middle of the hallway. Well, now's the time for you to go educate your patient on, these things. She'd never done that before. Never had the time to do that before, and so it was a struggle for a lot of them that had been there a long time and been so used to having to do all the clinical hands-on type tasks that otherwise they didn't have to do anymore. And so those were the places that we had to really work through, the pushback from the staff. And we had a few folks that just, nursing assistants that had been with us a long time that, they gave baths and got vital signs. That's what they did. And when you tried to train them to do dressing changes and remove Foley catheters and remove IVs and all those things we were asking and training them to do, that was a big pushback for them. And so, but we made it through that and helped a couple of them out the door, and that was all right. And you get people in that are just really excited to be there. And so again, there's been a lot of hiccups and a lot of bumps in the road, and we still face those every day. I told folks when we started, this is going to be we'll forever work this. We'll never stop working this. And we're in another phase right now. We're going back and looking at every single thing and seeing where we need to make improvements. We meet with the staff, the entire service line, twice a year. I require them to come in to like a town hall and meet with us and give us, their feedback on what's going on. It's one thing to go up and try to talk to folks on the unit, but they're busy. They got patient care. So we bring them, in for about an hour and just have a conversation about what's going on. And every time we take something back and we begin to work on it so we can just, show that movement. And we tweak Critical Alert a lot as a result of them telling us that this is not working like it should, and we'll go back and fix things for them. So.